So good afternoon, everyone. Welcome to this session on innovative practices in Housing First. So I need to begin with the land acknowledgement. You've probably heard the same land acknowledgement over and over again throughout this conference. So I'm going to make it a little bit different. It's going to start with the McGill University land acknowledgement, McGill being on in this city, and I've added a little bit. So this conference is taking place on land which has long served as a site of meeting and exchange amongst indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse indigenous peoples whose presence marks this territory on which peoples of many places now gather. And I've added the following. We seek to put into practice the calls to action of the Truth and Reconciliation Commission. And I would, if you haven't already done so, I would encourage you to read those calls to action. Most of them are directed at the government, so there's not a lot that we can do about those individually, but there are possibilities for us individually to assist, for example, through making donations to indigenous organizations that are working in that direction. So I would just encourage people to sort of move from the just abstract land acknowledgement to sort of concrete action, basically. So, that said, we will be listening to two presentations today. The first explores the impact of integrating virtual mental health services within Housing First programs. And the second brings together a panel of three experts who are leading work in harm reduction policy development and specialized harm reduction service delivery in shelter and supported housing contexts. So the first presenter is, the first presentation is entitled Enhancing Housing First Programs, Integrating Virtual Mental Health Services to Address Homelessness in Canada. Sonia Martins is with Athabasca University in Calgary.
Hello, everybody.
Sonia, you can take a good half hour.
Okay, thank you. You guys have been exposed much to a lot of practices and ideas through this conference. So you should be richer with ideas once you guys come together to collaborate, because you will be through the presentation. You already mentioned the topic at hand, but I want you to focus on the idea of integrating virtual mental health services to Housing First programs as a way of continuing care and ending or mitigating homelessness in Canada. A lot of you have been exposed to Housing First programs, so I would not dwell much on what it is. It's pretty much housing as a human right, and we've seen proven success with this in many regards, amongst which are reduced hospitalizations, reduced incarceration, increased income stability. However, we are seeing a portion of the individuals going through these programs or being exposed to these programs still facing many challenges. And one of the critical quality of this set of individuals is their mental health challenges they face. Through COVID, we've been exposed to being able to access care virtually in probably some regards. I don't know if any of you ended up interacting with your doctors through a Zoom call, or if you know someone that did. But COVID was a way to emphasize the proof of concept. It's been around for a long time. It's been a way to reach individuals with in rural areas away from physical access to clinicians in many regards, but COVID was one thing that definitely brought it home. We already know what it is, so I won't even talk about it much, but now you're only accessing care through these platforms. Some of the benefits that have been pulled together with virtual mental health services is its ability to increase access, especially when you do not have access to the physical professional on the other end. It's also been shown to reduce stigma, especially amongst our population, the homeless population, in the sense that they don't have to deal with the idea of walking into a space that is often professional in setting, and having to face, are you supposed to be here? What's going on? Type stigma. I mean, you could talk about why we should even be having that conversation, but stigma still remains a thing as much as we're trying to mitigate it as well. We also have a effectiveness of accessing virtual mental health services. Of course, there's always challenges with anything that has a pro. There's always an opportunity cost. Some of the concerns with our population includes the access to digital infrastructure and privacy issues, and even if they should be accessing this care virtually, they may not work for them. In our Housing First programs, the section of people that keep getting left behind are the individuals struggling with mental health concerns. That number is, I always wonder with the number, because this is a number from 2016, and I'm yet to see anything updated, and I know it's more than that, so I'll just keep that on the screen. But more important is that 30 to 40% of individuals who experience homelessness have mental health issues. And 74% of Housing First participants who return to homelessness have mental health issues. So that should tell us something, that we really need to cater to this population if Housing First is going to be impactful to them. So when I bring these two initiatives together, by prioritizing housing, we've seen some cost savings, system-level cost savings, compared to the cost of implementing Housing First program, with the numbers being $2.50 to $1. But the idea is when we combine access to care to allow for that continuity in care for these individuals, when we give them the convenience of reaching their health professionals and increasing access while reducing stigma associated with accessing this care, perhaps we'll see some benefits, some added benefits to long-term stability with these individuals. And that is the idea, to bring the benefits of one program, the Housing First program, with virtual mental health access, and hopefully we can mitigate the impacts of homelessness amongst... I felt sorry, I've been talking to this population. I'm gonna face you all now. And there's much benefits for everyone, to the individual, to government systems as well. I don't think I can overemphasize the goal. The goal of Housing First remains to increase housing stability as much as we possibly can. And the hope, the merging of virtual care, or the incorporation or integrating of virtual care would bring is the idea of access and continuity of care. All right, so this is why I've been emphasizing that you should be with a cluster of people. So if you're singly seated, perhaps come forward, and if by moving forward, you can start now, actually. Not to impose, but I really need you to merge with people, if you can. You have 1 minute. Thank you. Quick. All right. That works. Perhaps you guys could group together, like 5 of you. You can always move back to where you were seated before. I just need you to be with a cluster of people. And for you guys in the middle, imagine a line running through your middle. So are you 4 or 5? You're 5. You're 4. Okay. So 4 of you are going to collaborate with 2 of them behind. Okay. And you guys are going to collaborate with the gentle Manda. And so try to find a cluster. The faster we can go, the better. We have 15 seconds. Oh, I've adjusted that. So I had the 90 minutes before, but that was cut. So, all right. And now that you're settled, I would think, ignore everything on the slide, because that's no longer the plan. And the idea with this is I want you all to discuss amongst yourself. You guys bring a wealth of experience to this place. So in your conversations, I want you to, it's 3 questions. And I want you to think about it, think about the question, use your experiences, the experience of someone you may know, and address the question at hand. I'll read this question and then I'll show the code. So you only need 1 person per group to log into the code and write the answers down based on behalf of your group. Does that make sense? Okay. So yes, there will be a QR code. So I'm going to pull that up, but I want you to first delegate 1 person that's going to take a picture and impute the answers of your group. Okay. The people on the far side, are you able to? How do you for time? I assume you all have taken a picture? No one is left to take a picture? Oh, you need to? Okay. Hello, welcome. I'll need you to partner up with somebody. Perhaps the person in the back. Do you want to partner up with her? Oh, you're volunteering. You can still participate. We need... Pardon? That's even perfect. You may know... Honestly, you have an idea. So it might be nice to get acquainted to the subject matter by connecting with somebody. If you can find a cluster, you should. All right, we're going to get going. Oh. Yes. It should take you to menti.com. Did everyone get connected to menti.com? I will let you know. Just a minute. Sorry, this team. Does another person want to try connecting? Okay. Oh, the question has not been asked yet. What are you all typing in? I'm going to pose the question. I just wanted you all to be settled, so we just go quickly. Okay. All right. Let me escape this. Oh, no. I should present this. Okay. So here's the question. Drawing from lived observed experiences, what would it take to ensure every Housing First program participant can access meaningful virtual mental health support regardless of housing status, culture, or digital ability? I'll read that again. In different words, for individuals struggling with homelessness who may be accessing Housing First programs, what do you think it would take for them to have access to the mental health care they need, regardless of where they may be at? Oh, by the way, you have 3 more minutes to put in your answers. This is timed. Okay, you have 25 seconds left. Okay, so now we will move to the next question. Don't worry, at the end, after the second presenter, we'll get a chance to reveal the answers and talk about them in more detail if we have time. The next question is, think about a moment where care felt connected or disconnected. What partnerships, policies, or practices could help Housing First teams and mental health providers work as one system across virtual and in-person services? In-person is there, yes, because virtual mental health is not meant to be standalone. It's meant to be, again, for continuing the care beyond in-person. So what was in place when care felt connected, or what was missing when care felt disconnected for this individual's accessing care? All right, that's 3 seconds left, and we move to the next question. Again, I don't expect that you would have all the answers at this stage. The idea is to share and keep thinking about those things. So when you go back to your community, you can actually implement some of these or identify some of these in your community or field of practice. Third question. Based on your experience or stories you've witnessed, if your community could pilot an integration where we bring virtual mental health services and connect it with Housing First programs, what first step would you take and why? So if you could pilot this in your community, if you see a need for it, what would you be considering first? What would you want to see first? That was the last slide. Oh, that's tiny. Alrighty. The insights will be harvested later on and shared, if I can do that in the time. So chances are, through your answers, you may have considered certain elements that may be covered in the conceptual framework I'm about to share. This is basically bringing together concepts and ideas that we think what areas that would need to be addressed for this idea to be implemented effectively. Of course, many things rises and falls on policy. What policies, what rules do we have in place to even make it happen? In terms of the funding, in terms of how the programs are going to run, in terms of the privacy, online privacy, we're probably integrating a third-party app or software. So all of that is critical concerns and things that need to be addressed in implementing virtual care with our Housing First models. Suitability. Not everybody is going to want to use virtual care. Not everybody can use virtual care, virtual mental health care, because of the nature of their prognosis or diagnosis. So it will not meet everybody's needs, but for those it will meet their needs. Are we able to even give them the opportunity to utilize this platform? Infrastructure. We couldn't even talk about virtual services without Wi-Fi or devices that's going to connect these individuals, both on the end of the individuals experiencing homelessness and also on the service provider end, and also on the government's nature of compensation for if health professionals were given virtual services as opposed to in-person services. Of course, digital health literacy. Imagine trying to figure out things during a meet. That can be very distracting. And for both parties, it would end up like taking up time and not even being effective. So we need both parties, the individuals dealing with homelessness, as well as the providers, to be able to know how to utilize virtual platforms. That would involve a level of training. I did hear training from someone on this corner there. For the individuals or for the organizations providing housing first, if we're going to be integrating virtual mental health services into the program, we need to be able to know how to navigate the digital divide between your individuals accessing your programs. How do we also make sure our staff on site know how to have these conversations with these individuals? Should they be, maybe they missed an in-person meetup with their health professional. Now they may have to use a virtual platform as to close that gap. How are we going to have the conversation? For an organization that may not have that equitable capacity, it might prove difficult. Of course, cultural appropriateness. We've seen that culture does influence the perspective or the receptiveness of these individuals to even wanting to see their professionals online. And the magnitude of the benefits is very associated with the cultural references these individuals may have. And the way the service provider delivers care virtually can be, their cultural background could also be implicated in their delivery mode. Honestly, that's kind of this is just seeing how it all ties in. Homelessness, HF6, Housing First programs, virtual mental health care integration with policy and the components of policy that we're looking at, the suitability infrastructure, the digital health literacy. We need organizational capacity for equity and cultural appropriateness. How all of this is going to tie into the two critical things that virtual mental health care seeks to provide, which is improved service access and care continuity. And hopefully this enhances the mental health outcomes. And by enhancing mental health outcomes, you actually give these individuals opportunity to thrive in the Housing First programs longer. And hopefully they move past the Housing First program. Well, if we say Housing First program is more permanent housing, maybe they do better, basically, wherever they find themselves, and will reduce the homelessness recurrence. Honestly, that is pretty much the end of my presentation. This is all just talk to say we have to continue thinking about those things and seeing how best we can improve care and reduce housing instability that we're seeing in our communities. And I hope you have one or two things to take with you to equip your community better. These are references if you need access to the data. Oh, I'm so sorry. I closed the laptop. I'm sorry. It's a natural habit.
Okay. Thank you very much, Sonia. Our next presentation, if I can bring it up. Here we go. Our next presentation will be given by three people. Emma Bell-Scohan from the Toronto Shelter and Support Services, Brett Wolfson-Stofko from Homes First, also in Toronto, and Savannah Wilson from the Toronto Alliance to End Homelessness. And I hope, let me know if you have trouble handling the technology.
Okay, where's the little mouse? Here we go. I think we just need to do this. Nice.
Yeah, perfect, wonderful.
Okay. Hi, everybody. Thank you so much for coming. We do want to start by giving our own land acknowledgement. The land that we operate our programs and services in is Toronto, traditional territory of many nations, and home of the two-row wampum covenant, where the nation to nations are rowing alongside each other, sharing in collaborative community, something that does not happen, and as a result, we have a housing crisis that disproportionately impacts Indigenous communities. I also want to acknowledge that our friends are dying and the government is killing them. And I think that it's a really important thing to say. It's true, it's happening. And that the criminalization of drugs is rooted in racism, it's rooted in colonialism, and it is a direct attack on the right of people who use drugs to continue to live and be loved and love and thrive. And so, thank you. Yeah. And this war on drugs has never been about public health or safety. It is an attack on marginalized people. And as we share in our collective learning today, I think a lot of us are here because we're grieving. It's been a very difficult year for harm reduction. And there are a lot of amazing and powerful harm reductionists in this room. And for the front lines, I thank you all. So thanks for having us today. Today we have some learning objectives. So we're looking at harm reduction across the housing continuum. So what we hope to provide folks with today is an opportunity to think about the journey that people go through when they enter into the shelter system, all the way through to harm reduction supports and services they might be connected to while they're in sheltered homelessness specifically, and then what kinds of policies and operational practices that organizations that do supportive housing can implement into their own supportive housing units, all the way from abstinence all the way through to supported supervised consumption. Everybody deserves to have a harm reduction philosophy embedded into the place that they live, whether or not that place is an abstinence program. So we're going to talk about that today. And I just want to name too something that's out of scope today is unsheltered homelessness. We're not going to talk about that, but as we said, people are dying in the streets, and there's a really significant need for us to stand together and make sure that folks that are living rough outside also have access to harm reduction supports. But that is out of scope for today.
Okay, thanks. I'm going to read because I'm less strong at speaking than Savannah. So our presentation tries to bridge some conceptual and structural frameworks with operational dimensions of the topic that we'll be discussing, which is harm reduction across the housing continuum. But we'll take the next few slides to kind of set up the theoretical framework that we're working from. So we're really working from the position that a commitment to harm reduction is central to the meaningful application of a housing first approach. Why is this the case? As Savannah sort of alluded to, and we'll get into a bit more, perceptions of drug use rooted in its criminalization stigmatize drug users and impact their experiences across the housing continuum at every stage, from entering into shelter until and continuing on to their experience in housing. For this reason, people who use drugs face unique barriers in every step of their housing journey. And we see this in research coming out of Toronto, which reinforces some of the sort of risk factors that people who use drugs face, including increased experiences of violence in the shelter system, increased shelter discharges, and incidents of eviction. These risks are intersectional, and they're shaped and compounded by factors like race, disability, Indigenous identity, gender, and sexual orientation. Combined, these factors mean that drug use-related stigma and other risks at best have impacts that can be disruptive, such as sort of ruptures in a housing plan or casework, and at worst, the impacts are deadly. Data from Toronto, from the coroner's office for 2024 shows that drug toxicity was the leading cause of death for people experiencing homelessness. 48% of instances of death for males, and 76% of deaths of female identifying individuals. This is compared to 2% of the wider population. Building from this theoretical framework, our presentation will look at how a harm reduction approach and specialized services can be used to confront stigma and reduce barriers to accessing services. This approach must be integrated into spaces, into places, and into the people who are serving clients to support those who use drugs, to secure and maintain housing, and most importantly, to stay alive. So in other words, we can't meaningfully do housing first without harm reduction.
Right on. Hi, everyone. I'm Brett. So first, before we get into anything further, it is incredibly important that we start with understanding the drug war, how we got here. I'm usually very loud. Is to start how we got here with the drug war. And the first thing everyone needs to understand about the drug war is that it has nothing to do about the drugs. It is all rooted in racism and colonialism, as Savannah was mentioning earlier. And this all started with the first drug law in this country actually was the Indian Act, which forbid indigenous people from purchasing, selling, and consuming alcohol. But this law didn't apply to any other settlers. Go figure. Similarly, then, the Opium Act of 1908, that specifically banned the use and sale of smokable forms of opium, which were predominantly consumed by East Asian immigrants at the time. Yet, opium-containing elixirs and tonics were still readily available at pharmacies through mail order with no prescription, which were the predominant consumption method of, again, particularly European settlers. So this is by design. It's all selective, and it's all to justify state-sanctioned surveillance, harassment, and violence against minority and poor communities. It is by design. And so as they start banning all these drugs, there's still a demand. And so that leads to organized crime, mafias, gangs, etc., cartels getting involved in this because you can make exuberant profits as a result of all of this. And so the toxic drug crisis that we're in right now was created through prohibition, drug prohibition. And this is why we're seeing that someone might be familiar with the iron rule of prohibition, in that pretty much the tighter you try to crack down with like a law enforcement approach, something is going to slip through. And usually it's going to be something more potent because if you're smuggling drugs, you want to have the smallest package possible because it's easier to sneak through. And then when you gets to where it's going to be distributed, then you can dilute it out. This happened during alcohol prohibition, both here in the US, where it was predominantly hard liquor that was being trafficked and created, not beer and wine, because you got the liquor and then you can dilute it if need be. But the liquor was contaminated with methanol because it was unregulated. No one dies from methanol contamination or goes blind from it anymore from drinking alcohol because it's regulated. And we check it, and we make sure people know what it is that they're using. So, drugs, again, then essentially were banned according to who is perceived to be using them. Again, not according to harm, because if you look at all of the data for cost as well as for health, it overwhelmingly shows that alcohol and tobacco are responsible for the vast majority of harm for any drug, okay? So that then brings us to substance use and stigma, in which this criminalization, which is at the structural level, the macro level, it all kind of trickles down. So when you start criminalizing this and trying to then fund enforcement, you then don't have money to fund investments in housing, in healthcare, and social services, et cetera. And let's always just remind ourselves that no other health condition is criminalized and treated this way. Mental health, diabetes, cancer, nothing, because it's absurd. And at the meso level, at the more public level then, because of the prohibition, it trickles down then to just like media and just general consciousness of these stereotypes and negative attitudes and prejudice towards people who use drugs, and then them becoming scapegoated for systemic failures and just poor social policy, economic policy, housing policy, et cetera. It's their fault. And it's just an easy scapegoat, and it's been historically used that way. And then from all of this compounds, and then people who are using drugs then internalize this stigma. And this leads to people thinking they're dirty or they're bad because they're using these drugs, and that's also the language and how things are being promoted in society. And it leads to social isolation, and it leads to people being reluctant to reach out for any kind of help due to shame and fear of judgment as well. So, I got more. Just for those of you that aren't super familiar with harm reduction, it's a set of practical ideas and strategies aimed at reducing the negative consequences associated with drug use. That's generally how it's framed, but we use it every day. Seatbelts. Driving a car is inherently dangerous. Seatbelts reduce the amount of harm that comes to us, and that's similarly what harm reduction is doing with substance use. It's the same concept. And so some examples are syringe exchange, supervised consumption sites, condom distribution, methadone, buprenorphine, safer supply, compassion clubs, free DULF. And it's evidence-based and has been evaluated for over 35 years in a variety of countries and different settings. And it reduces HIV and Hep C transmission, reduces overdose deaths, helps connect people to treatment, and helps increase uptake of health services as well. It's rooted in human rights and social justice movements, and something to be very clear that the media is trying to do to divide everyone is saying that there is a dichotomy between harm reduction and abstinence. That is not the case whatsoever. Please do not be fooled. Some of the most adamant supporters of harm reduction are folks that are currently abstinent that I know and have been pushing for this for a long time. It's a continuum, and we want to support people and allow them to make the decisions that they want of what's best for them and support them along the way in their journey.
Great. Woo! Go Brett. So we'll now get into some of the more practical parts of our presentation, looking at strategies and approaches to supporting people who use drugs in the shelter system and in supportive housing, and some lessons that we've learned along the way as people representing organizations that have been doing this for a while. So I'll be speaking to the shelter context. Yes. Just briefly before I get into that, for folks who do not know, Toronto Shelter and Support Services, formerly SSHA, also known as TS3, is the City of Toronto's homelessness service manager, and we directly operate and fund the community agencies that are delivering emergency shelter, 24-hour respite, daytime drop-in programs, wraparound support services, and street outreach. Our ultimate goal is to sort of create a world where homelessness is rare, brief, and non-reoccurring. But at the most sort of more immediate level, we work to ensure that individuals experiencing homelessness can access temporary shelter and other wraparound supports and services, in line with some key service delivery principles, including client-centered and trauma-informed approaches. So in line with our mandate and the principles of service delivery, TS3 is committed to supporting people experiencing homelessness, regardless of substance use status. Whether someone is experiencing homelessness within or outside the shelter system, we understand that the presence or absence of substance use should not impact their access to or quality of services. Our experience shows that this commitment can be realized through the implementation of a harm reduction approach, sort of as a baseline and broadly, as well as specialized service interventions. Our current approach has been developed and tested over the last 5 years in collaboration with shelter operators and some wonderful community partners, many of whom are here today. And we kind of categorize this work into 4 key components. So the first is strategic guidance and sectoral alignment. The second is sort of tools for shelter operators, partnerships and specialized support, and centering lived experience and evidence in decision-making. So we've sort of developed a 3-step approach to supporting alignment across the shelter system to try and ensure that there is a baseline of harm reduction and other sort of service delivery standards across shelters. It is not quite there yet, but it is the goal that we're working towards, recognizing that in the current context, individuals don't have much choice where they end up when it comes to accessing shelter, and there should be at least a minimum sort of level of services that they can access, including specialized services around harm reduction and substance use. So our approach begins with a few key strategic documents that leverage public health and evidence and community-led best practices. These strategies identify priority actions and recommendations to support people who use drugs in shelter. And they provide the sort of foundation or the underpin this baseline of standard expectations around harm reduction and set future state goals for sort of the system that we're hoping to achieve. Some of these documents include the 10-point plan, which was developed by Toronto Public Health in collaboration with many harm reduction experts, as well as the Our Health, Our City strategy, which is our sort of citywide strategy. Importantly, at the second level, these sort of guidance documents and recommendations are integrated into the Toronto Shelter Standards. These are service delivery standards that apply to all shelter operators and that they're contractually obligated to implement. They include detailed overview or detailed enumeration of various harm reduction minimum standards and best practices. And as I mentioned, the goal of these standards is to create and enshrine this minimum baseline. Finally, to support operators with implementation and ensure some degree of kind of accountability and oversight for the implementation of standards, we have regular yearly quality assurance assessments where each shelter site is assessed on the basis of their implementation of standards, including the harm reduction standards. In addition, we have also this sort of more needs-based and collaborative harm reduction and overdose prevention assessment, which is a tool that where we work directly with providers to identify some needs and gaps they have around harm reduction service delivery and support them to sort of address those gaps. Through here's sort of a brief overview of some of the pieces that are included in the Toronto Shelter Standards. Something important to highlight here is that the standards elaborate that providers and shelter operators should not confiscate personal material or belongings of shelter clients. This includes substances, and that shelter clients should not be discharged for substance use alone. So to support providers and sort of set them up for success to implement the Toronto Shelter Standards, we've also developed a series of tools and resources that have sort of been built from specific requests and that we've received from providers. So these include a harm reduction policy guidance document and policy template, and a similar guidance document and policy template for overdose response and prevention, as well as sort of a suite of training and capacity building opportunities that we can deliver for shelter operators at their request. We have all the resources and tools available at this resource link, so you're welcome to check them out, and feel free to ask me if you have any more questions about those. Finally, or not finally, but additionally, we've established a well-tested model for supporting the delivery of specialized embedded harm reduction supports through a partnership approach. This may be repetition for a bunch of folks here because they're involved in this work. But we work very closely with partners, including the Neighborhood Group, Parkdale Queen West Community Health Center, LOFT, Toronto Drug Checking, and others. So a key learning from this partnership approach is that has been the importance of working and sort of maintaining long-term partnerships where staff are embedded and consistently in shelters over a period of time. We see that this has been effective to support relationship building with shelter clients building those relationships that where shelter clients can sort of iteratively over time work towards their goals. We've also seen that providing clients with multiple support pathways to seek harm reduction services beyond the shelter provider can reduce potential barriers to accessing these supports, especially as we reflect on the stigma that's associated with drug use and some of the repercussions or implications of that. Community health and harm reduction providers also bring specialized expertise to effectively deliver a range of harm reduction supports, and in doing so, they can build the capacity of shelter operators to do this work on their own. Some of these specialized supports that are currently in place in Toronto shelters right now include safer drug use education, enhanced overdose response, including oxygen administration, supervised consumption and drug checking, where appropriate exemptions are in place, and that is something that's, Anyways, system navigation and support towards accessing treatment and other health services, enhanced staffing in peak periods, and capacity building of shelter operators. Another key component to this sort of enhanced partnership model and approach has been the introduction of peer supports, and these peer supports have provided important and meaningful pathways for folks to access and engage with harm reduction supports and other sort of social and housing supports and services. Overall, our experience with this approach and model has shown that the availability of on-site harm reduction supports through a partnership model can serve to strengthen trust and rapport with clients, reduce and address stigma experienced by people who use drugs in shelter, and strengthen access to health services and other key social and community services like housing and housing workers. Finally, and then I will stop talking, the city is committed to centering evidence and lived experience in its strategies and planning and decision making. This includes through the establishment of the Harm Reduction Advisory Committee, which is a membership-based group of people with lived and living experiences who meet every 2 weeks and provide input on different strategies, policies, and decisions that we're making that impact them. At an operational level, the Toronto Shelter Standards also encourages shelter sites to establish harm reduction committees that are made up or membered by clients in shelters to feed into decision-making around, again, issues that impact them. Additionally, we regularly use data to, including fatal and non-fatal overdose data from shelter settings, to understand needs and gaps and prioritize interventions. And we work with partners to support new research, to advance harm reduction service delivery, and develop new strategies and tools to enhance this work. And here's a very quick just image of some of the work that we do around tracking non-fatal overdoses based on calls to paramedics from Toronto shelter locations. And this is sort of a key tool that we use to understand what's going on in the system and to map service delivery decisions.
All right, y'all. Next, I'm going to go through some pretty standard harm reduction procedures and strategies that we've been implementing in our shelters and supportive housing, and you can too. So some of the standard strategies we have is 24/7 barrier-free access to harm reduction supplies, so needle kits, crack stems, bubbles for meth and fent smoking, and foil kits for the OGs. And we have both intramuscular naloxone and nasal naloxone available. And we train all of our staff in overdose response on how to use naloxone, use pulse oximeters so we know how well the person's doing, what their blood oxygen level is, as well as oxygen administration with non-rebreather masks and bag valve masks as well. Hoping by the beginning of the next year at the latest, it'll be mandatory for all the staff to, frontline staff to be trained in oxygen. Right now it's on a voluntary basis, but all of our supervisors and site managers are currently trained. We also do require walk-arounds to be done by staff to check any kind of hidden locations where a lot of substance use occurs. Again, this can be it's a very private process for many, and so people are looking for privacy in an open dorm shelter, for instance. So a washroom, a shower, a secluded stairwell, and so we have a list of locations to be checked, and we now implemented these things called tap tags that you can see at the bottom here, where there's a wand that when you're doing the walk around and you see the little tag then on the wall, it goes, either beep or it vibrates or it just shows you that it's done. And so that we can keep track and ensure that people are actually doing the walk arounds and going and checking the locations that they need to check. We also have on-site pharmacy, so folks don't even need to leave the building to get their meds to help improve adherence. We have on-site primary care clinics operating, virtual psychiatric clinic, and also a virtual safer supply and opioid agonist therapy clinic as well operating. Again, so people don't even have to leave. We have to worry about getting them out of the building to get to an appointment right then and there. We also actively collaborate with our on-site harm reduction partners. Big shout out to TNG and for Loft for providing a lot of help and support, teaching folks safer use strategies like test shots, how to find a vein, how to care for your veins, and the importance of rotating injection sites. Providing peer witnessing services where possible, and also with helping train our clients on how to use naloxone because ODs happen outside of shelters and housing. So, everyone here has limited resources, and so there's a few things that we recommend in prioritizing in different spaces and different risk environments, which I'm not going to get into that right now. But in open dorm sites, having overdose prevention sites or a place for spotting or at least a space for use is really what you want, because then you don't have people using in the washrooms, clogging the toilets, and causing all these other types of issues. There's conflicts because someone has to go to the bathroom, but someone's in that stall and they can't get in. So needless violence. And so also it makes it much more likely that someone will be found and not die, and also any overdose response that's necessary can happen immediately to reduce the chance of acquired brain injuries, and also reduce community complaints if people are using outside of the shelter, okay? So the challenges always are funding, and of course, prohibitive legislation in which they do not follow the evidence that is available. And that was our beautiful OPS. That was one of our things. It's not that, it's just, you know, it's just a table in a room. No one needs to freak out over this stuff. And so for private rooms, though, since in in supportive housing sites, etc., we found that a lot of folks tend to use alone by themselves in the room. And so we recommend safer supply prescribing. We found the evidence is kind of mixed on the use of supervised injection facilities and spaces within like housing, because people have their own room, you know, listen to their own music, they're just doing their own thing. It's all good. And so we want people to know what it is they're using and how much, because that's the problem. That's why people are overdosing, because you don't know what's in your baggie. And all the drug checking results pretty much corroborate that. And so you can partner with a nurse practitioner, and a physician. And so like in Ontario, physicians can just prescribe this. And NPs can as well, off label. So it's totally cool. You don't need a SUOP grant or anything to do it. So make some friends. So again, people need to know what they're using, and some of the research is showing an 89% reduction in overdose deaths for those on safer supply. So I can't stress enough that y'all should jump on this. And you know, finding prescribers can be a little difficult, but it's doable. And in like Alberta, for instance, there is some prohibitive legislation. Cool. Over to Savannah.
Okay. All right. Thank you so much. So I'm gonna rip through these. These are now let's take you on a journey. This person has entered the shelter system. They have gotten the supports that they require. They've been supported in a Homes First shelter. They're using supervised consumption sites, and they're offered a housing unit. The housing unit is in a supportive housing building, and they get to the harm reduction in housing continuum. So, again, I want to really emphasize that when we're talking about supporting folks who live in supported housing, we are not talking about eradicating all abstinence-based supportive housing. Absolutely not. That is not what we're talking about. However, we are saying that even within the context of an abstinence-based housing program, harm reduction philosophy, harm reduction theory, and harm reduction practice must be integrated. So, what does that mean? When we're talking about abstinence-based housing, we are talking about options for residents who choose abstinence. This is a very important piece of the puzzle. If somebody decides that they would like to live in an abstinence-based housing, we want that available for them. And then some supportive housing is intentionally abstinence-focused, and so that means that there's no drug use on site. But that does not mean that there's no supports for people who choose to do whatever they want with their lives, including use substances. So if applying a harm reduction lens to a abstinence-based program requires planning for a possible return to substance use for all tenants that live in that building. That means staff needs to be trained in compassionate support, clear overdose response policies are available on site, and that there is an avoidance of framing abstinence as better or progress or your journey towards or the ultimate outcome. Because if we start to frame abstinence as better than substance use, then those folks that are in abstinence programs who decide they want to start using drugs again are not going to tell you that they're doing that. They're not going to come to you for supports, and they're going to have a much higher likelihood of an overdose death in their units because of the stigma associated with that. So if you move along the continuum, we go to off-site referrals. It's not required that you are abstinent in your home, but providers can refer residents to community harm reduction services instead of offering on-site services. So referrals can protect privacy for tenants. It can expand support options, but there may be some risk if substance use is unmonitored in any way or unsupported. So we're not saying, say, if somebody comes to you and is like, I would like to use drugs, that you say, okay, go over there and don't tell me about it. No, we're still saying that integrated into your program is overdose response, as well as harm reduction referral availability. Then we go into on-site support. So maybe you've got harm reduction workers on site, there's expert staff, there are tenants that can access safer use equipment, maybe they can get overdose detection technology installed in their apartments, whatever the case may be. But those services are available in-house, they don't have to be referred out in order to access harm reduction supports. And then all the way to advanced on-site services. So this can include managed alcohol programs, it can include oxygen therapy, peer witnessing programs, virtual supervision, as well as housing-based overdose prevention sites that are a potential model for the future. In Toronto, there currently are no in-house supervised consumption within the context of supportive housing. But I do want to underscore that the success of supervised consumption on site inside of a supportive housing unit or inside of a supportive housing building is really, really dependent on the program itself. And is only going to be successful if the approach to that program is rooted in community, in mutual aid, in building relationships amongst tenants, and building trust between workers and tenants. So that's a really successful potential model for the future. I want to talk a little bit about why supervised and why harm reduction is challenging in the context of supportive housing. And it is because supportive and social housing importantly offers privacy and autonomy, but it also includes increased overdose risk. So most overdoses occur when a person is using alone in their own apartment. We know that. That's and oftentimes that's because of a number of reasons, but they're using alone because of safety concerns, their own safety concerns. They're using alone because of stigma, because of the stigma we were talking about. Perhaps because of fear of eviction, because they're in a housing unit that responds to substance use with eviction notices. Or they have a personal preference. They like to use alone. So privacy rights and risks are important, but in the context of Ontario, the RTA requires 24 hours to enter a unit, which reduces the ease in which people could get wellness checks or to have wellness checks have their wellness checked upon without a 24-hour notice. So the RTA can get in the way of that a little bit. So some of the innovative practices that we've been hearing about when we did, because, don't get me wrong, the RTA is important, and every tenant in supportive housing should be protected by a Residential Tenancies Act. They should have protected tenancies. I want to just underscore that because that is critical. If your tenancy is not protected, it is not housing. But I will say that some of the ways that organizations have responded to that risk is to have consent-based wellness check programs. So you can sign up for that and say, I would like to be checked on. I'm going to use this afternoon. Can you come to my apartment between 2 and 4? Make sure I'm okay. So there's ways to respond to that privacy and risk with consent-based practices. And I also want to underscore the importance of community engagement and peer support. Common spaces, long-term tenancies, they help build peer networks. You move into an apartment building and you make friends with your neighbors. So peer-led programs like supply distribution or peer witnessing programs, those have proven to be extremely successful, and it's relationships of safety with other people. You don't feel as surveilled. It doesn't have that weird power dynamic that it has when you're like sitting there and your workers just kind of like hanging out in your apartment. Like, I think that could feel weird sometimes for people. So a lot of the times these peer witnessing programs can be an exceptionally successful response to folks who want to continue their substance use in a supportive housing setting. So we have really 3 key policy recommendations across the housing continuum in supportive housing. So all providers should have an articulated commitment to harm reduction principles and an outlined expectation for service delivery and staff behavior. Every single person that gets placed into a supportive housing should know what their rights are and whether or not they're going to be respected and how they're going to be respected by all housing providers across the continuum. All housing, even abstinence housing, should have an overdose prevention policy, so a plan to ensure safety, and then an overdose response policy, so robust training available to all folks that work in that space to ensure that if there's an overdose, it can be responded to and that life can be saved. And I'm going to give a little plug. I guess it's not a plug, it's an offer. We get nothing for this. You get to have these and use them as much as you want. There's 3 toolkits, but the 2 that are really related to harm reduction. So in the last year, we undertook the Toronto Alliance. Oh yeah, I'm Savannah. I'm with the Toronto Alliance to End Homelessness. We undertook a year-long study looking at innovative practices and policies for supportive housing contexts and developed toolkits. So these toolkits offer providers, everything from just like plug and play harm reduction policies that you can just like copy in your own organization's name and you have a policy, all the way through to guides for building partnerships to start delivering and developing co-led in-house harm reduction supports within the context of a supportive housing environment. So taeh.ca, and you can download these toolkits and absolutely use them and share them. And we're here because we stand in deep solidarity with people who use drugs and are or love people who use drugs. And we want everyone to be able to live for as long as possible. Thank you.
Okay, great. So thank you very much for that high energy presentation. So we do have some time. We have about just over 20 minutes for questions. So there's a microphone over there. So if you want to ask a question, I invite you to make your way to the microphone so that the question will be recorded.
Hi, I was just curious to know how your community providers have contended with the changes in how we're allowed to dole out naloxone kits now. We're finding I don't know exactly, but with new directives in our supportive housing, we used to just kind of leave naloxone kits out so anyone can grab them. We'd put them in the places where we knew people would kind of use. But now it's seeming like things are changing, and every person that you give a naloxone kit to, you have to make sure that they're trained and that they know how to use it. So we're kind of clawing back how we dole those kits out now. I don't know if that's something that...
Where are y'all at?
What's that?
Where are you?
I'm in Ottawa.
You're in Ottawa?
Yeah.
Interesting. Yeah. We have kits readily available at any time. There is training materials inside the kits. Ideally, providing even a 5-minute training is what you want to do. And so we do make the effort to try to go around to the residents who are living in their home, in their supportive housing units, and train them. And so train as many as we can, and then have the kits readily available. And their friends, their guests also come through and grab stuff. It's it's wild how safe of a drug naloxone is. It's safer than Tylenol, and never mind, I'm not getting into that now. But it is safer than Tylenol, and Tylenol's very safe. I think it's the concern. Any kind of concern with that is overblown, and there should absolutely be pushback to it.
Yeah.
It's unexcusable, I think.
Yeah, I definitely agree. I think we're starting to have to track how many we're giving out, identifying if someone is taking it, have they been trained on it, and so it's becoming very intense.
Yeah.
Are you guys tracking it based on the amount available, or is there something more? What is the limitation? Why the tracking?
We receive naloxone kits from partners, and if we are going to be the ones handing them out, it sounds like we're now responsible for identifying where each one is going.
Okay.
So something that we've been hearing a lot about is the integration of peer-led train-the-trainer programs, and then having just sort of shifts set up. So just in response to that, which also makes everybody much more safe because everyone should know how to use naloxone. If you don't know how to use naloxone, get trained today. But we've been hearing a lot about people setting up sort of these training programs. So if you come, you get trained, and then you also can sign up for a training the trainer, so that it's just widespread peer-based training of naloxone, and then that can sort of ease that sort of restriction a little bit. But go ahead.
Oh, sorry.
No.
So sorry. So just for the tracking thing, one thing you could do is if you are going if you need to track how many are going out, you have a centralized place where you put them, and whatever you just put out, you just be like, if you put 5 out, be like, okay, that's 5 that we will assume is distributed because they're gonna go. And so then you just track every time you refresh that stock, and you've got a nice little tracking mechanism for yourselves.
Yeah.
Yeah.
Thank you for the question.
Thank you for your question.
So thank you for both presentation. Like for the first presentation, I'm just wondering about like, because some organizations in terms of privacy and what they call kind of clinical safety, they prefer having like one-on-one in person in terms of psychotherapy. And as a clinician, I prefer in person, specific to trauma. I don't know how that part of the like the picture, like what is your perhaps your ideas about, or what will be your suggestions for those typical challenges when it comes to virtual in terms of some problematics in mental health. For the second presentation, thank you guys. I see your energy, and so it's I have both experience in abstinence for almost 5 years in like treatment center, and now in harm reduction. I think that we are all here in this country in the spectrum of stigma. All. We are all. We are all in that spectrum of stigma, from non-use to what they call problematic use. Myself, I'm not using any drugs, but I'm still in that spectrum of stigma, because everywhere I go where people are having fun and drinking, I have a ton of questions on the why I'm not drinking.
Yeah.
Yeah.
Absolutely
So,
right.
and I think that it's part of education. But I'm realizing that in Ontario specifically, because I'm in Ontario, we are kind of facing abstinence against, it's not versus, it's abstinence against harm reduction.
Yeah.
And abstinence is part of harm reduction, right? So, thank you. So, and my question here is because I'm a clinical lead in an organization, Supportive Housing. They call it Ottawa Solace, and we are part of the Heart Herbs. And we will be experimenting having a permanent housing 24/7 with the requirements of the government.
Yeah.
So I'm just curious about what will be your suggestion.
Right.
And I'm open also to have perhaps conversation with you guys after this. So thank you so much.
Yeah. Thank you.
Thank you for your question. I'll go first since the asked first. You're absolutely right. This virtual model does not work for everybody. It is meant to be, and it does not replace in-person services. If it's being provided, it's two things. It's meant to help with that increased access for some people who may struggle with the initial in-person appointment. I've had individuals, when I used to work actively in the field, I've had individuals who, could not make that first appointment for many reasons. They're not in they have other commitments, they are not able to make it, but they have access to a phone. And something like that could even bridge the gap. At least they know, okay, I've established a first contact with this health professional, mental health professional I'm going to be interacting with long term. And that has helped them have a more concrete vision of, okay, now for the next appointment, I'm going to make it priority. And it's also worked the other way, where they already have established contact with this mental health professional. But for that day, that period, they are not able to make it, and they're able to connect virtually, especially during COVID. And it worked. It helped them in that moment. So for virtual care implementation, for virtual mental health services, is two things. Is it even suitable for those individuals? and it is not replacing in-person care. I hope that answers your question.
Cool. So in regards to the heart hubs, which some of you may be familiar with, those from Ontario, these are meant to replace supervised consumption sites and safer supply programs, though let's be honest, they're woefully inadequate to do so and miss the mark by far. Like, it's not even a question. Then there's no evidence supporting the use of this model. So to be clear with that. And they're also prohibiting harm reduction supply distribution in any kind of heart hub. So since you all can't distribute, that's where the importance comes with partnerships. Yeah. In which they can come in and provide supports and provide syringe exchange, pipe distribution, et cetera, as well as naloxone and training. That would be one way to get kind of around that, or else you're going to see a lot of Hep C and HIV just going rampant then potentially, which would just be devastating and unnecessary for that matter. Yeah.
So do you mean kind of building a wellness strategy in terms of partnership with different organizations?
Yeah, having different organizations that provide harm reduction supports to partner with them and have them come on site and then kind of take over that. Is that what we're getting at?
No, you can't. You can't have. Jesus. Yeah. You can't have on-site harm reduction with heart hubs at all, even with partners. So, but do you want to?
Well,
I don't know if that's.
I think.
Figure out how to break the rule.
This one.
Where there's wiggle room.
I think it's complicated. Like,
Yeah.
I don't want to weigh into this. I think it depends on their.
Oh yeah. I'm on a leave, so I'll say whatever I want. No, just kidding. Just kidding. I think that the thing with the heart hub model is that it's so murky, it's so ambiguous. Nobody knows what the hell you're supposed to be doing. All of these funding agreements are just really nebulous. There's these you can, but you can't, and you can, but you shouldn't, and you. So I think that what we've been hearing a lot of is partnerships with offsite referrals and using mobile support services as a sort of a stopgap. And so if your organization can partner with mobile support services to have sort of roaming supports offered to fill in some of those gaps, it also provides an opportunity to kind of go around the 200-meter rule for SESs. Then there's, and delivery models for harm reduction supplies, and which again is something that we used to do because of legislation that prohibited. I mean, I'm from Saskatchewan, so I'm talking about that originally that context. We did a lot of that mobile supports to go around the legislation and sort of be able to deliver life-saving services within this very aggressive and adversarial legislative framework, which we're starting to see now in Ontario. We're in the middle of it in Ontario. So mobile support partnerships would be maybe a recommendation.
And the partners distributing supplies right outside.
Yeah.
And having to just leave some? Don't know. See, gotta get creative.
Sometimes we do sometimes.
It just,
Yeah, exactly.
Yeah, exactly. Any other questions?
Well, if there are no further questions, thank you very much to you all for being here this afternoon, and a big hand of applause to our panelists.